I'm only one call away. I'll be there to save the day. Superman got nothing on me. I'm only one call away.
Hello and welcome to another podcast. Today we're going to continue with the direct pharmacy health medications, and we're going to look at Phenoxymethlypenicillin. Now, the PCCMs allow us to use Phenoxymethlypenicillin for two types of conditions mostly. It is primarily used for complicated upper respiratory tract infections, and it also can be used for more mild and early cellulitis and erysipelas, but only for high-risk groups. The high-risk groups are Aboriginal and Torres Strait Islanders, which mostly live in communities of Central and Northern Australia. You can also use it for personnel that have a high susceptibility for Streptococcus pathogens, either by clinical presentation or local disease pattern within the area. But it's find what complicated one is. So the PCCM has given us their definition of what complicated upper respiratory tract infections are. Now, it's pretty much broken up into your two main classes. Now, there's the individuals, or the group of individuals that are highly susceptible to strep infections, as you mentioned, Aboriginal, Torres Strait Islanders, Pacific Islanders, and those linked with rheumatic heart disease and rheumatic fever. So Group B, hemolytic staphylococcus infection, is associated with rheumatic fever in adults, or can be a rheumatic fever, which is an autoimmune disease. And in children, they can get something known as scarlet fever, which is characterized by a red blanching rash, a strawberry tongue, and it's also due to a streptococcus infection. Now, in order to get rheumatic fever, it has to actually start with pharyngitis, which is why they're saying a complicated upper respiratory tract infection, like those personnel highly susceptible to rheumatic fever, is one of those cases that you want to treat this potential strep infection early. Now, when we look at the actual pustule tonsils, there's a lot of wive tales out there of what quantifies bacterial tonsillitis. So pustules on the tonsils isn't necessarily just bacterial. Okay, you can get viral tonsillitis that causes pus. You can get viral tonsillitis that causes fever, and some viral conditions will cause lymphadenopathies. Okay, so swelling of the lymph glands, or fevers and pus, is not indicative of a bacterial infection. However, the PCCM has recommended that when you get all three of those, so pus, a fever that's obviously caused by a prolonged infection, and lymphadenitis, then you're able to use Phenoxymethylpenicillin. Also, in the presence of quinsy, you can also use it straight away. Now, quinsy is a much larger tonsillitis that involves generally the closing of an airway, and if you do believe quinsy is present, then usually early evacuation, hospitalisation, IV medications, and sometimes surgery can be needed in order to fix that. So just have a look out for that. Okay, looking at Phenoxymethylpenicillin itself, it's part of the beta-lactam family, a very common family of antibiotics, and it's best taken on an empty stomach based on best evidence. Now, its bioavailability ranges between 60 to 75%. That depends on which area of the body its target area is. So you can get a 60 to 75% range, and usually, depending on the area, will determine the dose and the frequency in which you take it. There's a peak plasma time of 0.5 to 1 hours. Once it's in the bloodstream, it has a massive affinity to protein, so it sticks with the albumin, which prolongs its duration within the body. It's able to cross the placenta, but it has a poor blood-brain barrier diffusion. It is also metabolized by the liver, not just through first pass metabolism, but also subsequently from there. Has a half-life of 0.5, but also remember that it's highly bound to proteins, so it doesn't mean that half the drug is completely disappeared. It just means what's not bound to protein will be disappeared in the 0.5. Okay, and then it is subsequently excreted by the urine. Now, like always, if you need a refresher on pharmacokinetics, you can visit the previous lesson explaining all about pharmacokinetics and how it works throughout the body. Okay, but we'll move on to pharmacodynamics at this stage. Now, beta-lactams and penicillins in particular work on the bacterial cell wall. So, like most cells within the body, bacterial cell is also involved in making polymerase chains, so chains of peptides in order to replenish themselves and then also duplicate themselves through binary fusion. Now, if they're allowed to do this, they can strengthen their cellular wall with a polymerase chain, and then they can subsequently make further chains in order to establish growth and reproduction. What a beta-lactam does is it comes along and it will actually block part of that change. Okay, so it will inhibit the biosynthesis of the cell wall. Okay, so the micropeptide that is being built, mucopeptide that's being built on the cell wall will actually be blocked, and by blocking it, it doesn't allow it to actually finish, and then the actual chain that is being produced will break down. So beta-lactams are effective against gram-positive and gram-negative bacteria and bacteria with a cell wall, okay, which is a lot of different types of bacteria. Now, once the cell wall integrity has been destroyed, what happens with the bacteria is, depending whether it's gram-positive or negative, it will actually either allow the increased osmotic pressure of the cell itself to not be withheld within a wall anymore, and therefore burst through the membrane, causing the cell to actually be destroyed, or allow other bodies into the actual cell by having a huge osmotic draw, and the same response is going to happen. The cell membrane is going to burst. Now, depending on the dose that is given, these antibiotics are bactericidal mostly, but if only low doses are provided or short duration, things like that, then it will just become bacteriostatic and we'll have to rely on your body in order to break it down. Okay, as far as warning signs for our phenoxymethylpenicillin, we have our usual allergies, but this time it's allergies to all beta-lactams. So that is 100% all penicillins, definitely, but then there is also up to a 15% cross-link allergy present with our cephalosporins and our carbapenems as well. So there's a lot of antibiotics. So if someone's allergic to penicillins, then chances are they have a chance of being allergic to cephalosporins and carbapenems as well. So the PCCM provides alternative antibiotics that you can use in each case if someone does have an allergy to the penicillins or the beta-lactams. Now, like most antibiotics, we have the usual adverse effects that we can get. It's diarrhea, nausea, and oral candida. This particular one as well, we have associated with vomiting, seizures in patients that are susceptible to seizures, and anemia can occur in patients mostly with renal insufficiency, but you can definitely get hemolytic anemia, serum sickness, and even neutropenia for those people, like I said, with renal insufficiency or prolonged use or very high serum concentrations for an extended period of time. There's also a slight risk associated with patients with history of asthma, that it can be the IgE mediated anaphylaxis reaction, so the actual allergen based reaction of those personnel with a history of asthma. Now, like most medication, there's a strong interaction with other medications. The serious interactions are ones that play a big part, especially in our line of work. So if someone is on phenoxymethylpenicillin and they're going to get a cholera, typhoid or BCG vaccine that is live, it is best that they either wait for the course to be finished, or if they're due to have it and they must have it, then picking an alternative medication. Also, if somebody is taking your tetracyclines, you need to be really careful of a serious interaction, and our tetracyclines include our doxycycline. So make sure when you talk to the MO, remind them if they are already taking doxycycline, just to get the advice, whether they stop the doxy for a while, whether they take a lower dose, whether they take it over a longer period of time. There's a few options out there. Now, other things that aren't quite as serious but you still need to monitor is any of the other classes of antibiotics. So anything that's not a beta-lactam, you need to be careful because of interactions, as well as the morning after pill. Now, because of its strong and high protein bound nature of 80%, it also has strong interaction with any other drug that it has a high protein bound. Now, the reason for that interaction is because there'll be competition with the albumin of who's going to bind. So it will interact either way with that particular drug, and it may alter the affinity or the effects of a certain drug. Okay, so just keep that in mind. So it's always best to use the Medscape Interaction app in order to see if there is going to be something that needs to be taken into account with the medications you are providing. Now, the doses for the drug depend on the actual condition. So in the 10th edition for upper respiratory tract infection, it is 500 milligrams twice a day. So every 12 hours for 10 days. That's the way that is to be taken. Okay, now like most of the drug is the Schedule 4, so we need to consult a medical officer before giving the medication out, and always give it in accordance with the PCCM. Okay, if you're not dealing with upper respiratory tract infection and you're dealing with cellulitis instead, then it's the same dose for adults. Okay, it's 500 milligrams per dose for adults, but this time it's 4 times a day. Okay, so every 6 hours instead of 12 hours. And this can be taken for 5 to 10 days depending on how well it actually responds. Now, a few clinical take-homes. Main one is mostly similar with all types of antibiotics. Is one, be very careful of the adverse effects and monitor them closely. And two, also provide the education and the importance of taking antibiotics as prescribed. We all know about the link with superbugs, but more so is the prescription for the antibiotic is designed for the average person with the average condition that would take the average amount of time. Okay, so we talked about bioavailability and protein binding. So that's why there is a difference between your upper respiratory tract infection and your cellulitis, and it's very important that the person actually takes it every 12 hours or every 6 hours, 500 milligrams, doesn't alter the dose, and takes it for the full course. Okay, so it's part of your job to educate them on the importance of that. Now, if for some reason you think there's going to be a lack of adherence with the oral medication, then you can treat with IN benzylpenicillin initially. Okay, now, if someone has an allergy, the main drug that is used is azithromycin. Azithromycin is a drug that we'll cover off at a later stage, but it is not a beta-lactam. Okay, it is actually a macrolide itself. So therefore is not associated with the cross-linkage or the beta-lactam associated allergy. Now, it's always best that the person with these particular infections don't go to work for 5 to 7 days. It's not because they're completely useless and can't do it, it's mostly got to do with the risk of spreading it to other people. It is also highly advised that they wash their hands as frequently as possible so they don't transmit it to others. Okay, so bottom line is, if you have someone in the field that you are treating with phenoxymethylpenicillin because of the risk of a strep infection, because that strep infection has an associated risks with rheumatic fever, especially in community living or field, for lack of a better term, there's a huge risk of transmitting that infection to others. So it is always best to evacuation from the training environment in order for them to get the proper treatment and the isolation. Okay, that ends the lesson on phenoxymethylpenicillin. I hope you got something out of it. The next drug that we will cover off on the list will be Microlax. But until next time, take care.